We present our experience with combined transurethral bipolar enucleation of the prostate and robot-assisted simple prostatectomy. Large gland prostates are traditionally candidates for enucleation, open simple, or robot simple prostatectomy. Each has its advantages and disadvantages. We attempt to capitalize on each of the advantages and maximize operative time by combining approaches. The robotic approach has been associated with shorter hospitalization time, shorter catheterization times, and less blood loss, however carries the disadvantage of longer operative times. In addition, the postoperative urinary incontinence rate is still 1 to 2%. The holmium laser enucleation offers the alternative to the robot's simple prostatectomy with improved transfusion rates, catheterization rates, length of hospitalization stays compared to open prostatectomies, however still has a prolonged operative time comparatively. When comparing the HOLUP to the robot-assisted prostatectomy, the HOLUP is favorable for operative time, transfusion, catheterization time, and hospitalization time. Bipolar enucleation of the prostate has been compared to holmium laser enucleation of the prostate. The only advantage for holmium laser enucleation of the prostate with morcellation was operative time. When comparing bipolar plasma enucleation of the prostate versus open prostatectomy, there were similar operative times, however favorable catheterization times, hospitalization times, and transfusion rates. In addition, there was superior incontinence rates after the bipolar enucleation of less than 1%. We explore the possibility of combining a transurethral bipolar enucleation with robot-assisted simple prostatectomy in order to optimize operative time while maintaining low transfusion rates and urinary incontinence rates. Our index patient is a 67-year-old gentleman in urinary retention with a trust volume of 165 grams. He was a candidate for robot-assisted simple prostatectomy. We elected to perform a combined transurethral bipolar enucleation with the robot-assisted simple prostatectomy. The procedure is initiated by marking the verumontanum with the medium loop electrode. The mucosa surrounding the verumontanum is incised. Next, a channel is created at the 6 o'clock position from the bladder neck to the previously marked apical incision. While this portion of the procedure is underway, the second surgeon is placing the ports for the robot. Once a channel is created, we use blunt dissection to peel the adenoma off of the posterior attachments, widening the groove down to the level of the capsule. Next, the mucosa next to the verumontanum is incised, and the apex is peeled off with blunt dissection. Electrocautery is used only when necessary. Once the posterior apical attachments are freed, the beak of the scope is used to sweep to the 12 o'clock position, freeing the anterior apical tissue. Next, the remaining lateral and posterior attachments are freed. Once the posterior attachments and lateral attachments are freed, we now move towards the bladder neck anteriorly. The mucosal bridge is incised with plenty of length away from the sphincter to minimize chances for urinary incontinence postoperatively. Here, the majority of the right lobe can be seen completely enucleated other than the remaining bladder neck attachments. The process is now repeated on the left-hand side. The left mucosal bridge is now incised. We now turn our attention to the robot portion of the procedure. As a rule, we try to get as much done as possible transurethral before converting to the robot. However, we've not spent more than 15 minutes with the enucleation portion of the procedure. We do, however, want to maximize the apical dissection with the transurethral approach because we believe this minimizes the chances of postoperative urinary incontinence. It will keep the rate of incontinence less than 1% as it is with our transurethral bipolar enucleation patients. Now that the bladder is opened and the stay sutures are in place, we begin by using a tenaculum to retract the prostate and incise the mucosa. Once the mucosa is incised at the level of the bladder neck, we can easily get into the previously dissected plane. Once we're in the plane, the prostate is easily removed. Here, anteriorly, there were a few attachments that had not been enucleated transurethral. However, we knew these would be easy to approach robotically. Importantly, the apical mucosa is completely enucleated prior to initiating the robotic approach. Hemostasis is obtained. A bladder mucosal advancement stitch can be performed if desired. Surgiflow is applied to the prostatic fossa, and the Foley catheter is placed on light traction. The prostate is placed within an endocatch bag and the stay sutures are removed. The bladder is closed in 2 layers. We have 5 patients in our series thus far with more than 4 months of follow-up. Age was 69. All patients were in retention preoperatively. The preoperative volume was 194 on average. The total surgical time was 124 minutes on average. EBL was 75. Postoperative PVR was 2 milliliters. IPSSOR was 3.8, and post-op PVR was 2 milliliters. Importantly, none of the patients in our series have experienced postoperative urinary incontinence.